Good afternoon, good morning, good evening, and a warm welcome to the third episode of this WHO Let's Talk Primary Healthcare. And this is our fourth edition of the series. So my name is Tony Dedeu. I'm the Senior Advisor for Primary Healthcare at the WHO European Centre for Primary Healthcare. And I'm pleased to host and to moderate this today's talk show. So today we'll navigate into the complexities of the topic of bridging rural access gaps for greater equity. So health equity and access gaps highlight disparities in the health outcomes driven by social, economic, environment, contextual factors. And this is something that is even more relevant in rural, dispersed, isolated, and remote areas. Our guests today include practitioners, researchers, policy advisors, policymakers, but they've got one thing in common. They are all advocates of rural health. Our panelists will dive into the topic, and specifically, this topic is multifaceted. So we have to learn quite a lot of the different aspects that influence in rural health. And then, right after the panel, the talk show, we'll invite you to join to the deep dive sessions. There are two breakout rooms. One is in Russian language, and the other one is in English. And meanwhile, what you could do is check in the chat, say hello, say where you come from, where you're connected from, and our colleagues are going to upload some of the references that the panelists and the discussants have suggested for today. So with this background, what I would like to do is to welcome and introduce our panel and guest discussants. I'm going to start with Veronika. Veronika Rasic is a family medicine doctor, a member of the European Rural and Isolated Practitioners Association. To simplify that is EURIPA, as you can see at the background of John. And Veronika is the founder and director of the Rural Health Compass. And Veronika is going to let us know a little bit more about what the Rural Health Compass is. Giovanni Baglio is an epidemiologist and the head of the research unit at Agenas. Agenas is the Italian National Agency for Regional Health Services. But at the same time, Giovanni, you are a coordinator of a very interesting project, the EU co-funded project called OASIS. And you're going to explain us that because the focus is on medical deserts. Then with us, we've got Miriam Nielsen. Miriam, you are a family medicine doctor, that you are working in a remote town of Storuman in the region of Lapland in northern Sweden. And what you are doing is that you are a real rural family medicine doctor in practice. So thank you very much for coming here. And I've got the pleasure to introduce my colleague in the WHO, Anne Johansson. Anne is the WHO representative to North Macedonia, but Anne has a long career in many managerial and policy assessing many ministers and many key people in worldwide and as well now in North Macedonia. So, and we've got a discussant. So our guest discussant is a pleasure to have here John Vin-Jones. John Vin-Jones has been a rural GP for more than 37 years, I think, in Wales, in the United Kingdom. He has now retired from the clinical practice, but he cannot retire completely. So he's still a part-time professor and lecturer at the University of Kiel in the United Kingdom, and at the same time, he still works for the Rural Wonka. And for you to know, Wonka is the World Organization of Family Medicine Doctors. John is, what I would like to say is that John founded the UK Institute of Rural Health and the Welsh Rural Postgraduate Unit in the 1997. So, and he was instrumental in creating Euripa, and he used to be the president until 2012. And he, furthermore, what he did is was one of the founding members of the Working Party on Rural Practice of Wonka as well. And he took over a chair position in 2013 from Professor Ian Cooper. So, and before I proceed with the first round of discussion, I would like to invite John to set the scene about caring for people living in rural, remote, isolated, and dispersed areas. So, John, please, the floor is yours. John, we are waiting for you.
Thank you. Thank you, Tony. Our theme today is not new, and we're aware that inequitable healthcare has been provided to rural communities for a long time. And I believe that in a modern world brimming with technology, we can surely provide high quality care for rural and remote communities across Europe. Andreas Stamper, who many of you will know, who was the author of the WHO Constitution and arguably one of the most important public health authorities of the 20th century, wrote in the New England Journal of Medicine in 1938 about the lack of health professionals working in rural areas and the inadequate training they received to meet specific rural health challenges. He highlighted the importance of raising the level of health literacy amongst the rural population and ensuring that healthcare providers must listen to and engage with populations they care for. It appears that little has changed since then. You will hear today from expert colleagues based across Europe who will describe the many barriers they've encountered and the solutions they've instituted to address them. Without doubt, one of the most pressing is the issue of workforce. Rural healthcare access is limited to a number of rural healthcare is limited in a number of European countries because of a dearth of healthcare professionals. These areas are sadly expanding and have been termed medical deserts. One may provocatively even argue that parts of rural Europe may not be able to claim universal health coverage for all the rural population at some stage in the future. Not only do we see a crisis of recruitment and retention in an already aging workforce, but in general, the current workforce is not necessarily trained to provide a greater range of services in order to meet the needs of rural and remote communities and provide care that's usually delivered in secondary care in urban regions. We need to train a multidisciplinary workforce that is appropriately trained and fit for purpose. And can we accept the generic training that our current healthcare workforce receives? This idea of one size fits all, which is inappropriate, possibly for rural and remote healthcare. Are the barriers between primary care and secondary care inappropriate for rural healthcare? Access to care is more than just associated with who provides the care. It's about the design of healthcare systems and the use of modern technology. The old adage still exists. If you can't take people to the services, then you must bring the services to the people. The barriers to equitable care are many, and a healthy rural economy leads to better investment and better services. Central government investment in infrastructure, local government, health service design, and support for traditional and high technology industries can see rural communities taking their rightful place in the nation's progress. Policymakers must listen to and engage with both rural communities and the rural healthcare workforce. Rural proofing is crucial to forming rural policy. It aims to understand the rural context and to ensure fair and equitable policy for rural areas. Rural proofing for health is about finding the best ways to deliver healthcare policies in rural areas. Meeting the rural health challenges and bridging the access gap needs an evidence base with which to move forward. And our aim today is to start to build that evidence to ensure greater rural equity. I hope that you'll all join us today and that you can engage in this debate now and in the future, either in your own localities, your own countries, but also across Europe. Thank you very much.
Thank you, John. Thank you very much. And don't go, because we'll hear from you later. And I would like to say that after John's reflections, let's go to the panelists. And John said something that's very, very relevant. It's bring the services to the people. And with us, Miriam, you are a rural doctor. And let's describe the challenges the citizens face in the remote area where you work, and how is the facility and the context you work in?
Yes, well, I'd say that Sweden, it's a large country in European terms. I believe it's 15th size in Europe, but with fairly few inhabitants. So for comparison, it's twice the size of the UK, but it has only approximately 1/7 of its population. And also most people live in the south parts of the country, and so large areas are sparsely populated. The north of Sweden, where I work, it comprises half of Sweden's area, but with only 10% of its population. And in certain areas, the population density is actually 1 person per square kilometer, or even less than 1 person per square kilometer. And I work at what would be best translated as a cottage hospital. It's like an expanded primary and community healthcare center. We have a regular clinic. It's open Monday through Friday, 8 to 5. But we also have the possibility of admitting inpatients in our ward. And from my little town, the distance to the nearest hospital, it's a little more than 100 kilometers. And if you need to go to a fully equipped hospital where they have pediatrics and hand surgery and things like that, it's another 130 kilometers. So, and apart from that, also the patients sometimes have 70 or 80 or more kilometers to just get to our little unit first. So we have large areas and very, very long distances. And that has always been a great challenge, both for patients and for healthcare workers. And so obviously it's also a challenge to actually attract doctors and other healthcare workers to move to these areas and to stay in these areas. And that makes it difficult to have this patient-doctor continuity, which we all know is so important for public health. And it can also be hard to motivate patients to come for regular checkups or to seek medical care in time, actually, because the distances are far and one tends to think that, yeah, this will pass, or I'll do it a bit later when the timing is right, and so on. And of course, also the distances are a great challenge when time is really, really of essence, when you have emergency cases like trauma, myocardial infarction, stroke, or the like. But this has also been a breeding ground for innovative and smart solutions to try and overcome the challenges. And that's one of the reasons that in Storuman, where I work, we have the Center for Rural Medicine, GMC, was started by one of my colleagues there. And that has now been designated a WHO primary healthcare demonstration platform. And that's obviously something we are very, very proud of.
So thank you, Miriam. Thank you. We'll keep listening more about your work in Storuman, in the area where you work. And now I'm going to move to Veronica. Veronica, you are also a family doctor, but today you are going to share with us about the reflections from your network, and then one of the things, the Rural Health Compass. We would like to know what are you doing and what are the key mains of that, because we know that the network is an advocate for better health access for rural communities. Please, Veronica.
So as has already been mentioned, the evidence shows that rural people in most countries have poorer health outcomes. And it's important to know that 83% of the European territory is rural, with about 30% of the European population. And often these populations, as has been mentioned, struggle to access essential services such as healthcare. And I founded Rural Health Compass to try and address these inequalities with a particular focus on helping rural communities and organizations navigate the rural health and policy space, which can sometimes be confusing. So it's important to understand the needs of rural communities, and it is only possible by interacting directly with rural people and local organizations. They are the experts on their context, and they live in the rural area and know how these things impact them and their families. Rural communities should be seen as a source of knowledge, and local government and policymakers should see them as partners in improving the health and well-being of communities and regions. Whenever possible, policymakers and service developers should include rural citizens in the early phases of development, and they should seek feedback during the implementation of their different programs. We should try to move more towards a co-creation of services, as this makes it more likely for the services to be used and for the services to achieve the desired outcome and positive impact. The kind of co-creation and community engagement also develops trust and allows policymakers to rule-proof their ideas and programs, which is vital to know whether they need to continue or make further adjustments. The health system is not the only thing that determines a person's ability, though, to lead a healthy life. And when we think about the well-being of rural communities, we must look at the social determinants of health. So where people are born, grow, live, work, and age. And for example, if rural people have poor housing, no public transport, or have poor internet access, these factors will also impact negatively on their health and well-being. At Rural Health Compass, we're trying to use a social determinants lens and a systems thinking approach to explore how social innovation can be used to transform services and improve the health and well-being of rural communities in Europe. I'd like to also emphasize that there is a mismatch between the very welcome recommendations that we need to be achieving universal health coverage and investing more in primary healthcare, and what is actually happening on the ground in Europe, and particularly in rural areas. So often these investments are not happening. With a push for further digitalization, as was mentioned as well, in healthcare, we must be mindful that there is a growing digital divide, and this will further increase the health inequalities in rural areas. If we do not address this during the digital transformation, that could also cause problems further down the line. I guess my main message in this first part would be that we really need to listen to rural communities and to rural clinicians that are working on the ground. And as part of this, I also created a podcast, The Rural Road to Health, which is trying to amplify rural voices. So I would very much encourage people that are interested in hearing from kind of grassroots rural practitioners and rural organizations that are working on the health and well-being of rural communities to have a look at that podcast and listen to experiences. Thank you.
So thank you, Veronica. And for the audience, you can find these links, and the podcast is also in the chat box. And now I'm going to, what we know is that we all agree that we need evidence. And it's not enough with the narrative experiences. And Anne has always worked by having evidence in mind and generating evidence. And Anne, you've been working in several studies, and one of them highlights the various barriers hindering effective health service coverage. I introduced the word coverage here, including issues related to availability, accessibility, acceptability, and organizational complexities. And could you give examples of how the insights gained from the study you carry out in North Macedonia and others that could address the identified barriers? Anne, please.
Yes. As you said, we've done a study using data from a nationally representative phone survey, as well as a deep dive, a qualitative study into the barriers of access to care in 4 municipalities in North Macedonia, rural areas, high proportion of poor population and underserved populations. And what we were looking at were the specific types of barriers that you mentioned, and particular variations on them across different population subgroups, because it's not clear that every underserved area and every underserved population group faces the same barrier. So this was an attempt to really systematically identify how people were facing the kinds of barriers that we were studying. And so what we found in these 4 municipalities was in general actually very high rates of variations in things like access to care due to, limits to access to care due to financial constraints, due to transportation, due to discrimination, lack of access to specialists, and organizational barriers. But at the same time, we also found some general barriers, such as for the Roma and patients with NCDs, they were consistently had faced greater barriers across all the sets. But we also found that we were able to compare what the average rates were and what were the these in across the country and what were the barriers in these areas. And what we've done is we've used this information to identify efforts to address the barriers specific to these. And right now we're in the process of developing new primary healthcare zones of populations of 30 to 60,000 people who are therefore able to address much more effectively than doing something at a national level, the specific needs of the people in that population. And so in this way, you can get much more granular data to allow you to address the specific barriers because, as I said, they're not the same. They vary across regions as well as population groups.
So thank you so much, and I think now is the link that I'm going to create with Giovanni is so strong because what your narrative, what you said, and what Giovanni is working as head of research in the unit in Agenas. So this is something that it makes full sense. So Giovanni, you are the scientific coordinator of the Oasis project, which highlights this topic as a main issue. So could you give us a brief description of the medical deserts? And I think you asked me that we could focus on the problematized and how is it measured, what you're doing in Oasis. Please, Giovanni.
Thank you very much and good morning, everyone. Thank you for having me today. As you rightly mentioned, Oasis was a project co-founded by the European Commission that ended last February and involved, besides my country, that is Italy, 6 other European countries, France, Cyprus, Romania, Moldova, Hungary, and Finland. And the project aimed at defining and sharing methodologies and knowledge on how to measure medical deserts in order to develop common policies and strategies to successfully address the challenges posed by underserved areas in European countries. Medical deserts is really a complex phenomenon, which entails several dimensions. In general terms, it refers to any situation where criticalities arise in the dialectic between health needs, demand, and supply of healthcare. And therefore, not only the simple lack of health services or workforce in a specific area, but also situations where quality is poor or where specific subgroups of the population are not able to have access to healthcare. When analyzing medical deserts, there are multiple perspectives which we can represent and summarize in the form of 3 fundamental questions. The first question to be answered is, are there services? I mean, are there enough facilities and health professionals? This is a dimension of availability, which can be considered in terms of presence in a given territory, but most importantly, in terms of coverage of the population's health needs. The second question is, if there are services, do they work? This is a dimension of quality. how good services are. In fact, having services that do not work properly is evidently a form of medical desert, and quality can be further declined in terms of performance of providers, but also in terms of protection ensured to the resident communities. And the third question, the last question, is the services that are there and that work. Do they work for everyone in the same way? This is a dimension of accessibility and equity. We know that specific subgroups of the population are often unable to have access to health programs and services in terms of travel distance or travel time, or because of linguistic, cultural, socioeconomic factors, or policy barriers that may hinder access. When all these aspects come together, a medical desert can be considered as a full medical desert. And it is important to be able to monitor all these aspects over time, because we must consider that the medical desert is not a static situation, but an ongoing phenomenon, a process which is not sufficient to identify and measure once and for all. And the challenge for European countries is to converge on a common set of measures applicable in different contexts and sustainable both at national and local level in order to develop common policies and intervention plans.
So thank you, Giovanni, and this gives me a space to move back to Anne, because you've mentioned some countries, and Anne, like in many other countries, North Macedonia has attempted to address some of these barriers in the past without, and this is one of the things, lasting successes. You, Giovanni, have highlighted the 3 key questions we should ask, and what will need to change if North Macedonia is to succeed in time? Anne.
This is a very complex problem. And in order to address it, it's really essential that you look at the root causes. And so WHO in North Macedonia last year carried out a study to identify and better understand the root causes contributing to these barriers over time. And what we found was really very revealing. I don't have time to share all the details, so let me just highlight a few of them that are particularly important. There is a complete lack of technical staff related to primary health care and to health systems in general in the Ministry of Health. The staffing is based on political affiliation, not just in the ministry, but in healthcare institutions. And that means they're not selected on basis of skills. And reforms are therefore developed in working groups established by the Minister of Health, but often without any input from the ministry. And so you have zero ownership of these reforms. And so it's not really surprising that things don't happen. But there's another contributing factor, which is that there's no one responsible for the performance of primary health care at either the central or local levels of government. You might say there's really no institutional home for follow-up. And in addition, there's a complete lack of capacity in the Ministry of Health, other public agencies, and other ministries to develop strategic plans to support implementation, to monitor and evaluate performance of health systems in general and the primary healthcare system. So, one would actually wonder why anything would work given this situation. But at the same time, with so many barriers, it's clear that there are no easy fixes. There are so many things that require systematic changes that go beyond the Ministry of Health, which requires both commitment and leadership by the highest level of government, not just the ministry. So we've developed a 2-pronged approach. short-term interventions that are feasible within this existing system. You might call them quick wins, to show visible results and develop credibility of the ministry. And then longer-term system changes, public administration reform, professionalization of the civil service, etc. Now, specifically in North Macedonia, what we're working on is a reorganization of the ministry, which we can do without broader civil service administration reform, and the establishment of a policy analysis team with capacity in strategic planning, health system strengthening, and who members of this team will serve in every policy development initiative and working group. And they will also develop a mechanism to monitor performance. We are also designing institutional homes for primary health care at both the local level in the primary healthcare zones that I mentioned before, and linking them to a national central institutional home to monitor performance. And then finally, I would say that all of these initiatives are being developed in part with support of 2 staff on special assignment hired by the WHO board for localized in the Ministry of Health to support these things, because nobody else has time to really move these things along. So that's a quick description of the initiatives that we're working on right now to try to create sustainable results on primary healthcare development.
Thank you, Anne. Thank you very much. And I think we would like to hear from a success story, but a success story from the practitioner side. And I'm going to invite now Miriam to explain your daily work. And what is the role that you are doing with the multidisciplinary teams that are established in Lapland and the Scottish hospitals there, and the work you do within the catchment area?
Yeah, well, as I said earlier, our cottage hospital is open on regular office hours, and then we work with regular primary healthcare patients. But of course, that varies a lot between countries as to how exactly we go about our work. But many things are no different in our parts of the world than in others. I mean, we have patients with high blood pressure and diabetes and asthma and otitis and common colds and the like. But because of the long distances, we also get to act on emergency cases. And sometimes we can treat them at our unit, and sometimes we'll just do our best to stabilize them before sending them on to the hospital. And because of the reason that we are where we are, we only have 1 ambulance at our disposal. And when that one's off, it can be many hours before we get it back. And sometimes we have the possibility to call for a helicopter if the weather cooperates and so on. But what we do in Sweden in general, as in many other countries, of course, we work a lot with digital solutions. And for instance, we have our medical records are digital. And so among other things, we send prescriptions via the system directly to the pharmacies, and a patient can then get their medication from any pharmacy in the country, really, as long as you have your ID. And at the cottage hospital, we also have we have an X-ray machine where we can examine suspected fractures, and that's quite unique for the north parts. And obviously, one of the reasons is all the snow in winter, where people go skiing and snowboarding and so on. And the number of people visiting the north during winter season is very high. And then the X-ray images will be stored digitally, and then they'll be examined at the hospital by a radiologist on call. And then we'll get the answer digitally back, and we can then put the cast on the patient or send them home if there was no fracture, or for that matter, send them to the hospital if need be for surgery or the like. But and apart from the regular daily patient work, I'm also responsible, together with a colleague, for our home healthcare or home nursing, and also the nursing home that we have in our little town. And there we have some 70 patients who are still able to live at home because of the service that they get from us and from the municipality with a home care service. And it's mostly elderly people, but also terminally ill, for instance, cancer patients, and who wish to be able to spend their last time in the safety of their own home. And they can do that because of these systems.
So thank you, Miriam. I'm really impressed, because one of the things that Giovanni said before is the three questions, and one of them, if there are services, do they work? And this is one thing that we see, that in your case there are services that work. But another thing that I'm very impressed is that you are motivated as well. So we are motivated. And now I'm going to ask Veronica. Because we know that Miriam said how rewarding is working in a remote and rural area, so it's rewarding professionally. But Veronica, why is it so difficult to attract young healthcare professionals in those areas? So,
yeah, it's a very good question. And I think it's important to recognize that most healthcare education happens in cities and urban settings. So young healthcare workers, they lack exposure and experience in rural areas. And this experience is vital if they are to feel comfortable choosing a rural health career. So most countries in Europe do not have rural training pathways for nurses, doctors, or allied health professionals. And it can be very difficult to find information about rural health or rural health careers, even if you're interested in going to work in a rural area. To reflect a little bit on my own personal experience, so during my family medicine training in Croatia, I was sent to a rural village due to a shortage of doctors in the area. And this was my first real encounter with rural medicine. And I was faced with a population that required a lot of care, and I had very few resources to provide that care. And this quickly resulted in my first experience of burnout, unfortunately. And so these factors contributed to my decision to move to the UK and continue my training there. If I had received rural-based training and support, perhaps the outcome may have been different. And this is one of the reasons why we started Rural Seeds in 2017. And Rural Seeds is a global network for students and early career professionals with an interest in rural health. We're a project-based organization with Rural Seeds ambassadors from all 7 global regions. And we currently have over 500 members. So we have hosted online family medicine cafes where we discuss relevant topics to rural health, and these are available now on our YouTube channel. And we've also created different projects like the Mentor-Mentee program, which was designed to help young rural clinicians feel more comfortable working in a rural area by getting support from more experienced rural practitioners. So our information about all these projects can be accessed on our website. And I'd like to also mention a more recent project that we started, which is called the Rural Stars Project, and it's aiming to develop a practical guidebook to support rural clinicians in advocating for rural health in their local setting. So we're hoping to have that available in 2025. I'd also like to reflect on the importance of how we value and talk about primary care, and particularly rural practice, to our students and to our clinicians in training. So in many countries, the narrative around rural clinicians is that they are the ones that weren't good enough to practice in the city or in the hospital. And this narrative needs to be addressed and challenged. Rural clinicians often have many skills that they need to work in challenging environments and provide the care that their rural patients and rural communities need. So I guess to summarize this, I would say that we need more good rural practitioner role models. We need to start developing rural training pathways with placements, ideally longitudinal placements in rural settings for these people so that they can experience a rural setting and make an informed choice about their future career. And as part of this, we also need to develop academic rural practitioners. So there needs to be an investment in this kind of knowledge base. And I would like to end it there for now. Thank you.
So thank you, Veronica. And now I'm going to move. I think it aligns very well with Giovanni. How can we relate medical deserts to rural areas? And there are another question. And which main criticalities and findings emerge from your research related to that? Thank you.
Well, thank you. It's a very important question. Well, the project has provided an overview on the current state of art of medical desertification in Europe. And we have found that every situation is in its own way peculiar. As Tolstoy, who is a Russian writer I love very much, wrote many years ago, all happy families are alike, and each unhappy family is unhappy in its own way. And this is because of peculiarities we can find in each situation. But some similarities can be traced in different countries. For example, shortage of medical doctors, especially in the field of primary care. Talking about Italy, if we consider, for example, general practitioners, the coverage rate is about 7 per 10,000 inhabitants, less than France, which has 13.8, or Germany, which has 10.4, or Spain, which has about 9 per 10,000. But in some areas, especially in northern Italy, the coverage rate drops to 5 per 10,000 in some provinces, which means about 2,000 persons assisted by one general practitioner. On the other hand, in many regions in the southern Italy, the coverage is higher, but the percentage of general practitioners over 65 years old is more than 50%. And this tells us that throughout the country, coverage could worsen in the coming years, a reason to be concerned. Another problem stems from the difficulty to access to care due to an unequal distribution of services, of health services. There are situations where services are really hard to reach. And in this regard, the issue of rural areas clearly emerged from our analysis, as medical deserts are mostly located in rural and low-income areas. And the impact of medical desertification on rural areas is generally more pronounced because these are areas lacking not only health services, but also many other essential services, such as schools or transport infrastructure in general. And for this reason, we believe that the progressive involvement of rural communities in analyzing and addressing medical deserts would be essential. But it has been observed that medical deserts may also occur in the context of overcrowded urban areas, where services are insufficient to meet the health demands of the inhabitants. This emerged, for example, from the pilot studies carried out in Cyprus, in Finland, but also in Italy. And telemedicine in the future could partially address this accessibility issue, but at least in the early stages, this is not necessarily going to happen because telemedicine infrastructure is often most lacking precisely where there are no services. And therefore, we need to carefully monitor these aspects in the near future. Thank you.
So thank you, Giovanni. Thank you very much. And now we are entering the last round. And I'm going to ask all of you to be very concise. We are a little bit running out of time. So I'll like to start with Miriam. I know that you perform many interventions and you have skills that they are not common practice in many GPs and family medicine doctors, specifically in urban areas. So could you give us some insights of those interventions and skills and competences that you developed and you deploy in your area? And what are the expanded services that the Cottage Hospital provides? Miriam.
Thank you. Well, for starters, I myself am from the south of Sweden and I still live there. So I travel to and from my workplace in the north regularly. And the distance is some 1,300 kilometers. So I work certain weeks physically in the north and then certain weeks digitally from home. And this is made possible because of the system we have with telemedicine. And right now, for instance, I have a home period. So I'm sitting in my own home and having digital meetings and phone meetings with my patients. And I also do the rounds with our nurses at the home nursing. So every Thursday I'm there. I mean, physically I'm there with them when I'm up in north, but right now I'm doing digital rounds with the nurses. And we can even visit patients in their homes. The nurse will be there in person and she'll bring a tablet and then we'll be connected through that. And it works very well, actually. I was quite surprised of how well it works, but it does. And so at the cottage hospital, we have a nurse in place 24 hours a day and a doctor on call outside of office hours. And it's all year round, 7 days a week. And when I'm on call, I'm responsible not only for my own cottage hospital, but for 3 more. And they are situated some 100 kilometers away from my own and fairly close by North Swedish standards, but still. And so in every cottage hospital, we have a video link to the emergency room, and I can connect from where I am, which could be any place in the world, really. And I can see the patient, I can ask the nurse to examine specific things for me, and we even have a close-up camera for a more detailed view if need be. And so the teamwork is, of course, essential. I need to be able to rely on the nurses, and they need to be able to rely on me. And so basically we all need each other in the teams, and the nurses we have, they are absolutely outstanding, and that's necessary to get this work together. And for me to be able to be responsible for my own patients, to have that continuity, and that's possible because of the digital solutions and the telemedicine, and like being able to do the rounds and so on. And so this has made it possible for me to work with rural medicine, something I've always wanted to do, at the same time as I can still live at home where I have most of my family and friends. And so the way I see it, I get the best of 2 worlds, really. And for the patients who can now get to have their own doctor, and that has been hard to achieve earlier, and of course is hard to achieve still. But for them, I would dare to say that these solutions to address the topic of today's session is truly bridging access gaps for greater equity.
Miriam, this is amazing. Such strong messages that many of us should incorporate in our mindset, but not just us, so the decision makers as well. Because one of the things I see is the adverse risk to innovation where you are working, and at the same time the cultural change in the organization. So this is a very good example that there is possibilities, to attract professionals into the rural health areas. So, and I'm going now to move to Giovanni. And Giovanni, you've been talking about the medical deserts, and now one of the things that I would like to ask, we heard from Miriam that the things are implemented where she works, but how to develop and implement effective policies to address medical deserts? Be quite concise, please.
Thank you. Based on the findings of the OASIS project, we can make some suggestions in order to strengthen the capacity of public health authorities to reform their health systems and successfully deal with the challenges posed by medical deserts. First and foremost, national health systems should strengthen primary care. Through a reorganization of territorial networks of services and professionals, encouraging coordination, skill mix, and task shifting in order to ensure a rational redistribution of tasks among health workers and to make more efficient use of the human resources available for health. With particular reference to Italy, the issue of medical deserts assumes an extraordinary importance at this specific moment when we are rebuilding the national healthcare system after the pandemic, after COVID. And we want to do this precisely starting from the criticalities and gaps that have emerged, sometimes even dramatically during the pandemic. Second, today more than ever, technology is constantly increasing and playing a strategic role in healthcare. This requires investment in digital health infrastructure and telemedicine to improve access to healthcare, especially in underserved areas, and with particular reference to the most marginalized groups of the population. Finally, as pointed out before, we need strong and effective actions that lead to the regeneration of rural areas, focusing on the enhancement of local resources, according to the slogan, grow your own. And in these regards, it's important to implement strategies for retention of health workers in remote and rural areas. And this includes, for example, refining the way students are selected and educated, as well as creating better working and living conditions in order to incentivize professionals to stay in areas that are less attractive. And this strategy collectively aims to address the challenges of medical deserts by enhancing availability and quality of services and increasing accessibility of healthcare in a perspective of equity and social justice. Thank you.
Thank you, Giovanni. And I think now I'm moving to Veronica. Veronica, when speaking about medical deserts, what else might we need to think about before? And I think Giovanni just talked as well about recruitment and attraction of medical healthcare professionals. And Veronica, maybe you would like to add something here. Please.
I'd like to build on what Giovanni said and maybe turn a bit more of a focus, particularly on those social determinants of health and also the life course of our healthcare workforce and what they need as human beings. So there is a WHO guideline on rural workforce development that I'd encourage everyone to have a look at. And in that guideline, they've identified 6 factors that healthcare workers look at when they're thinking about working in a rural area. So the first one would be personal factors. So things like, do they have a rural background? What career stage are they in? What are their values? Do they have any family ties in that region? Second would be family and community. So is there good quality schooling in that area? Is there childcare available? Are there employment opportunities for their partners? Are there community facilities in the area? And is there a good recognition of their role in that particular community? Third are things like mandatory service. So are they required or obligated to work in a rural area as part of their service? Fourth is career and education related factors. So this would be things like rural focused training and other professional development opportunities. Then there's the workforce and living condition that Giovanni mentioned. So is there good infrastructure in that area? Is that a safe environment to work in? Do they have support and what's the workload going to be like? And finally, is the financial aspect of benefits, allowances, and the salary that they might have. And as I said, you can find more evidence of these push and pull factors in the WHO guideline, and I would definitely recommend that you have a look at that. Additionally, EUREPA has published a blueprint for rural practice in Europe, which has recommendations more specifically for the European context, and I'd encourage you to read that also. And to address the challenge of medical deserts, we also need to focus on rural development and strengthening rural communities and revitalizing rural areas. So a healthy and thriving community and region is much more likely to attract and retain their healthcare workers. I also believe it's very important to encourage and support the development of national rural health strategies. So this type of strategy would show that national governments are thinking about the healthcare needs of their rural populations and that they value rural healthcare and rural healthcare practitioners. And at the EU level, the European Commission has supported the development of the EU long-term vision for rural areas. And this is a very welcome recognition of the importance of rural areas in Europe. And it recognizes that there needs to be more of a focus on rural development and the revitalization of rural areas. They have also launched a collaborative platform to encourage work across sectors on rural issues, and this is under the coordination of the EU Rural Pact, and I would definitely encourage everyone to also have a look at that resource and join the discussion there. Thank you.
Thank you, Veronica. And just for the audience to know, some of the references that Veronica has been mentioning, they are uploaded on the chat, so you can see them. And now, to close this round of questions with the panelists, I'd like to address to Anne. And your study served as a pilot of the forthcoming WHO handbook on assessing barriers to health services. Can you discuss the value of this handbook in guiding other countries to assess barriers and promote health equity effectively?
Yes. The handbook is a very practical tool for the systematic study of barriers to accessing health service in rural and underserved areas that have different kinds of vulnerable population. It enables countries to use an evidence-informed approach to assessing barriers, and it is informed, as you already mentioned, by a Tananashi framework for effective coverage with health services, which employs a combination of nationally representative quantitative data combined with qualitative data, qualitative studies of the barriers facing different subgroups in different rural and underserved areas. The framework explores 5 different dimensions of access: availability of coverage, accessibility coverage, acceptability coverage, contact, and effective coverage. And it does so by identifying which subgroups are not getting services that they need due to specific barriers like financial barriers, lack of transportation, discrimination, lack of access to special list services, organizational services, and quality-related reasons. And these will you'll probably remember these mentioned in the study that we did in North Macedonia. Really, the key use of the handbook, I think, is that it allows a country to really explore on a more granular level the types of primary healthcare reforms that you need to develop to address the specific needs of subgroups. Because, as I said earlier, the barriers facing different subgroups are different. So this allows you to develop targeted mechanisms for these, but it can also be used as to inform health financing reforms and inform program-specific reviews. And finally, I think it points to the need for monitoring the success of these reforms in addressing the specific barriers for rural and underserved and vulnerable populations. So it's not enough just to monitor the average of what's happening, but really focusing on these specific groups.
So thank you so much, and I think this is an excellent way to finish these rounds of discussions. And I'm going to ask now a very difficult exercise to John. And first, thank you for your patience. And I would like to hear from your reflections, but we are very tight on time, so try to summarize as possible your reflections. John, please.
So I was just unmuting. Wow, what how can you do this in a short period of time? It's a fascinating discussion. We've had on one side family practitioners, on the other side senior policymakers. We've had a social entrepreneur and a GP in Veronica, and I think she is an entrepreneur in that sense. And we've had a senior researcher. And it's important taking this forward. Looking at some of the challenges, I've got a huge scribble of paper here, Tony, but we've looked at the challenges of distance, of continuity of care, on managing emergencies, the lack of services in areas, of the barriers, and in particular, medical deserts, and some of the extremely fascinating work that's been done on measuring these. But now we've got to move on to the next stage with these medical deserts and how you deal with them. So I think that's crucial. What really interested me was Anne's comment about the lack of understanding in health departments. And I think even in some of the most sophisticated parts of Europe, actually, there is a lack of understanding of primary care. and Veronica mentioned this as well, that actually the focus has always been and will always remain, unless we change it, on secondary care, yet over 95% of the people accessing care in rural areas are access it through primary care. So there needs to be a big change in that. Veronica spoke about the workforce. I mean, it's my special interest. I could go on for forever on this, but it is about how you recruit, how you train, how you support a workforce. And she said that we've got to see it under the cloak of social determinants of health. One of my heroes who created the first free health system in Europe, and Irene Bevan, said that a health service needs to be universal, equitable, comprehensive, high quality, and free at the point of delivery. We've created health systems, even in some of the richest countries, but we haven't dealt with the inequalities. They're still there, and ours was created in 1948. Going on to talk about bringing services to the people, I thought it was fascinating, about smart solutions, about virtual rounds, virtual wards. We don't necessarily have to be there, but we have to be careful that that doesn't interfere with continuity of care. There was an article in The Lancet this morning talking about the end of doctoring, where medicine has stopped being a vocation and now become a job. So we've got to be careful about that. And I think Anne mentioned this thing about you've got to think local when you're developing these solutions. You can't have national views. You've got to develop zones. And I've seen that happening in Brazil and also in Kazakhstan. We've got to listen to the rural communities. We've got to and Veronica talked about rural proofing. I can't tell you how important rural proofing is, because it's actually developing the services that that are most applicable to rural areas. And we've found, certainly in the UK, and I know in other parts of Europe, you find central policy actually makes healthcare access worse in rural areas. A lot of interesting work on medical deserts. I think from an evidence perspective, we've for so long been dealing with the evidence that comes out of places like Australia. We are now building our own evidence base, and I think that's really crucial. Anne talked about the handbook and the barriers, and I think that's really important. And Tony, I could go on forever, but I just want one more heading, and that's getting the message across. And we've got Veronica, who's actually getting that message across, and getting it across not amongst the scientific community, but getting it across about the communities. We need to go out there. We need to use social media. We need to do all those things. So look, I think there's great hope in this, Tony, and thank you for allowing us to vent our feelings and to come up with some of those solutions. Thank you, Tony.
Thank you. Thank you. I would like to say thank you to all of you panelists and discussant, John, because I've seen all of you nodding to what all the rest were saying, and now I think this discussion could go forever. So and I invite you to our deep dives, sessions, because maybe some of the things that you've been hearing, they resonate to you, but at the same time you have the opportunity to keep talking to some of the panelists. Sadly, not all of them can join, and then at the same time we would like to hear from your experience, your country, related to this. So please find the links in the chat box. You will be able to see the links now in English and the English deep dive session and the Russian deep dive sessions. My colleagues Zofia Pirova will be moderating the Russian deep dive, and my colleague Jose Cerezo is going to moderate the English one. And one of the other things, before we disconnect, we would like to receive a survey. You are going to receive a survey, and there'll be a pop-up window, and this is really important for us to know how we are doing and what topics you'd like to hear about the future editions. And please fill it out. This is in English and in Russian. And with this, I would like to say goodbye for now, and thank you for your attention, to the panelists, to the discussant, and to all the audience. You keep joining with us, and looking forward to seeing you now in the breakout sessions, in the deep dive sessions. Thank you very much to all.